So this patient, she has actually a long history of advanced breast cancer. She's actually gone on about 12 plus years. We've treated several times when she's been a real advanced state. She's actually improved a lot, but one issue she's got is she's got some lesions in the sternum that have broken some of the bone in the sternum. She also still has a lesion in the breast. Other areas are starting to look good, like her lungs and some lesions she had in the abdomen. But we're going to treat more on this breast lesion because we can get immune stimulation through this by doing the pulsed electrical field ablation and then doing intratumoral immunotherapy. And then we've already did pulsed electrical field a few days ago on the sternum, and then we'll come behind and put a bone cement to help hold the bones together so that she doesn't have pain from there, because that was one of her issues, was the pain. And unfortunately, when she was at home in the United States, nobody really wanted to do anything to help her, so we've got to try to take care of all the main issues. So initially, I use for the breast, I use an ultrasound. Go in and first numb up, even though the patient's sedated. We still use lidocaine. It's actually been shown that injecting lidocaine into the tumors, not only does it help with the pain, but it actually has anti-cancer properties, actually boosts the immune response. So when you combine and doing intratumoral immunotherapy or ablation, you actually want to numb or put some lidocaine into the tumor itself. Okay, I think we can treat there. So with the pulsed electrical field, the thing this is done particularly to stimulate an immune response. It's not just to try to kill cancer, even though you are killing cancer. And it's not like some other ablation techniques where you go and you try to kill 100% of the cancer. We actually know if you kill too much cancer, it can be immune suppressing, probably because you're releasing too many dead pieces of tumor and the immune system will get overwhelmed. And the other is that we've actually done some studies looking at this where the residual tumor actually begins making immune stimulating substances itself. So it's really interesting. It's like a self-destruct. So by partially treating the tumor, you get a better immune response. Okay, we can step on it. The pulse electrical frequency sends a very high voltage charge that's like 1/1,000,000th of a second into the tumor. That opens up pores of the membrane. It opens up pores in the organelles, the structures inside the cell, and the cell dies in a very immune stimulating way. Some of it is apoptosis, probably other aspects as well. The thing that we've seen with pulsed electrical field is that you get generation of what are called tertiary lymphoid structures. These are groups of immune cells that get around the tumor, forming almost like lymph nodes, but they're basically like little military bases of the immune system, sort of organizing their attacking cells all around the cancer. And this pulsed electrical field, of all the ablation technologies that we know and have used, this one seems to be the most immune stimulating. And of course, when you combine it with injection of immunotherapy into the tumor, that's even enhancing it further. So it's really pushed the field along a lot with this. This is newer technology that was FDA approved last July, so 2022. Okay, we'll do one more and then we'll inject.
Okay.
And then we'll inject the sternum after that, yeah.
Okay.
Yeah, the problem in the sternum is with under fluoroscopy you can't see it quite as well. It keeps changing back and forth, but we can see so well under ultrasound. It's part of the tumor it's softer, getting softer than what it was the other day. See how it's changed? Yeah, like particularly that's where we focused at a lot before, and look at all the brightness, the increased echogenicity. That's the one thing that's nice with ultrasound is like.
Do look PET with her?
Well, we will at some point, yeah.
Okay, not right.
No, we'll wait. It's just too early. But yeah, like the nice thing with ultrasound is you can see the changes.
The coherent
Yeah, faster.
of the therapy.
Yeah, faster than you see them even on CT. So you kind of know, what areas to target. That's why I like using ultrasound when I can.
You see that change?
Yeah. After this one, we'll inject the immunotherapy at least. Yeah. All right. Ready to inject some immunotherapy. Oh, can you touch my ultrasound? Thanks. It's always a great satisfaction ablating tumors and injecting immunotherapy.
And see a change.
Yeah, I see a change in the tumor. It's rewarding to kill cancer right away.
De ahí ya tengo esas.
Dr. Moss, good to see you.
Good to see you too.
A pleasure to be able to talk with you.
Same here. We have talked before.
We've talked before, yeah. Actually, I was telling Ben, the first time you and I talked, I don't know if you remember, this was 2004. I remember I was at the University of South Alabama. I was on a big long bridge by Mobile. I was on my cell phone talking with you and was discussing with you about that we were doing ablation and that we were seeing tumors that were distant, that were shrinking or going away. And you were like, oh, that's the abscopal effect, which was the first time I'd heard that word. So I had to go look it up.
Well, I've followed your work from afar and admired it, and I've read your book and I thought it was excellent.
I appreciate that.
I don't feel that way about too many books, but I'm a bit picky. I'm very excited to talk to you.
I appreciate that. Yeah.
I don't know if you know this, but I had prostate cancer about 7 or 8 years ago, 7.5. And I was treated with ablation.
Yeah.
At New York University. They do cryoablation. So I have a personal interest in this. I know that this is, extremely promising approach.
Yeah, it's definitely the future. It's been a little bit slower coming along than I thought.
Yes.
But it's gaining ground.
People should understand that there's a long history to this.
There was actually a book written about cryoablation in the 1800s. In the late 60s, there were some prostates where I think they injected liquid nitrogen into the prostate, and then got one case they reported a complete response in bone lesions.
Yeah.
So
That's the abscopal
that's
effect.
right. For us, when we started doing radiofrequency ablation,
Uh-huh.
was in our first 10 cases, we saw 2 patients who had a complete response when we treated just partially. We treated a couple lesions with the plan that we were going to just keep ablating and doing it, and then some of their cancer all went away.
Yeah.
And so then we realized, okay, there's an immune response going on, and then what can we do to make it happen more? And we first started injecting interleukin 2 into the ablation site and
Uh-huh.
interferon, and those things didn't make a huge difference. It wasn't until about 2011 we started using some vaccine adjuvants.
Mhm.
There had been some animal work done, which really helped guide our treatment, and that's when things kind of took off. And then you got the checkpoints came in
Yeah.
right behind with the Opdivo and Keytruda, and we had, of course, Yervoy in 2011, and all of those really accelerated. And just now, there's so many immunotherapy options coming along.
Right.
So yeah, one of the agents that we've used, CPG, is what eventually Dr. Old, who I think worked with Coley's daughter,
Yeah.
had identified as being one of the active parts of Coley's toxins, which
Yeah.
essentially is what we call a toll-like receptor agonist. This is something that the immune system knows is dangerous, sees it as dangerous, recruits immune cells. And it's one of the issues with the standard immunotherapies. So many people now are on the PD-1 inhibitors like Opdivo and Keytruda. But if you don't have immune recruitment to the cancer, then those drugs don't have really a chance to work. And that's unfortunately one of the reasons that it fails in the majority of patients. And so CPG, being essentially single-strand DNA that's found in bacteria or some viruses,
Yeah.
is recognized by the immune system. And when you inject it into the tumors, particularly in combination with some of these other drugs, recruits those immune cells, you get the immune infiltration, then now the checkpoint inhibitors can work. And so that's the thing that's really interesting. So it's like a refined version of Coley's toxins. Instead of
Absolutely.
giving the bacteria, you give the actual specific agent. Patients that come to us, a lot of times what they do, they have to submit their records and their imaging. And so we review all those and determine, if there's somebody that we can help. Usually we'll have a consult with them remotely. They can certainly have it in person if they like. And then when they come here, depending on the cancer type, so you have some situations where, let's say you had an early cancer, like a breast cancer, you could do cryoablation alone. But then if you've got advanced cancer, which a lot of the patients that we treat are advanced, those are patients where we're doing ablation combined with immunotherapy, and we're repeating that. These are mostly outpatient procedures. There's sometimes the patients, if we're doing the lung, we might keep them in the hospital, but otherwise we'll treat them. They'll stay about half the day in the hospital. Obviously, we do the majority of our procedures in Cabo San Lucas, Mexico, which is a very nice place. We're in a full service hospital, and then we do these weekly, depending on the type of cancer. For example, like if it's lung cancer, a patient might need weekly for 3 weeks. If we're dealing with pancreatic or colorectals, those are more resistant. Those are going to at least be probably 6 weeks or possibly longer in some cases. And of course, we're scanning and looking at the patients throughout the process and seeing how their tumors are responding. And so that's we're injecting directly into the tumor, so we're able to use less drug, even though we do more combinations. That has less side effects for the patients.
So which are you doing first, though? Are you doing the immune stimulation or doing the ablation?
We actually do them together, both together all the time. And one thing I just want to let you know about is there's a newer ablation technology called Pulsed Electrical Field. And that actually seems to be more immune stimulating than cryoablation. Yeah, in animal studies that actually beat the PD-1 inhibitors head to head with only ablation. So really immune stimulating technology. And so I think overall for a lot of cases, particularly your advanced cases, this is a better technology. It actually connects with the EKG. You place the needle into the tumor, sort of like if you're doing a biopsy. The one thing that's nice is this has a needle and a needle, so you could place a needle, then it has an electrode that goes into that. And you target several areas of the tumor, so you do these overlapping ablations. They take about 5 to 6 minutes for each spot. That does about a 1 centimeter area volume.
Mm.
And so you hit those, and then you have your needle already in place, so you can inject the immunotherapy right through that needle. Don't have to place another needle, which is nice.
Yes.
And so, yeah, it's a really amazing technology. There's very few systems that we were the first to get it, and I think there's only like 7 systems in existence. But it did get FDA approval. Got FDA approval only with 30 patients. The other thing that we do in most cases is we use tocilizumab, which is an IL-6 blocking drug. And that was actually shown to reduce the side effects but enhance the immune responses. I mean, single milligram doses will actually have a major effect. You know, when you think about it, you look at the mouse studies, a lot of those are, you know, a quarter of a milligram, a half of a milligram, and they're getting major effects with it intratumoral. And so, you know, when you're thinking systemically, obviously there's a huge difference between mouse and humans, but actually when you're looking intratumoral, the differences are not so big because, you know, the immune cells are the same size, the tumors are, you know, they obviously can have bigger tumors and maybe you need to use more agents, but you can really get an amazing response with low doses.
No, I think you're a rare physician who recognizes this, and you're on solid ground in terms of the empirical evidence.
So one of the things, of course, is that, you know, a lot of these immunotherapy drugs have very little penetration into the tumor. And so when you're injecting directly into it, and a lot of times we'll use like a gel or another agent to hold that into the tumor itself, and it'll slowly release. But then you're getting that in the tumor. You've got the potential of the tumor antigens, the pieces of tumor that the immune system's going to see. Those are actually there together with the immunotherapy, going to, you know, those antigen presenting cells, going to the local immune cells in the environment. I mean, when a lot of these drugs are working on immune cells, and you really want it affecting immune cells that are around the cancer, not immune cells that are elsewhere in the body that have no interest in fighting cancer. Technically, you know, we started first injecting tumors probably about 2004. So we were doing ablation, did ablation work.
20 years.
Before. Yeah. So we have an idea of what immunotherapies may work, but then we can do, there's a technology called nanostring, which is a DNA barcode technology, and that allows you on a single specimen, you can look at all the immune receptors. I think there's 770 different ones. You could sequence the entire genome if you want as well. You could look at all the metabolic profile of the cancer, everything, all in a single specimen, and that's really allowed us to learn a lot with these cancers, where if we're treating somebody and we're seeing resistance, then we can start analyzing their tumor and figure out why are they resistant. We do have a clinical trial right now. We've got one for prostate, and we've got one where we're doing basically numerous solid tumors to see which ones are the best responders. We kind of know that overall with the 4-drug combination, breast and lung are some of the better ones. Prostate is very good. But if we can get the 4-drug combination approved, then we can try to build on that.
On another note, tell me about what you do and what you recommend for your friends and family members in terms of preventing cancer and in terms of lifestyle.
Yeah. Well, I think one thing, the big cancer risk relates a lot to the microbiome, which of course also relates to lifestyle, diet. If you don't have the right bacteria in your intestines, then your immune response against cancer is not going to be as good. We know that immunotherapy, there are several bacteria that are key to having a good immune response. We try to get our patients really kind of tuned up. It's not just like, okay, we're going to give you these drugs and that's it. We want to make sure their microbiome's good. He's coming to get me. Yes, I appreciate it. Yes.
I'm glad that we finally had a chance to.
Yeah, Dr. Ross, I appreciate it.
We finally had a chance. Very interesting, very, very productive. I'm sure our viewers are going to love this show.
I look forward to talking more. There's so much stuff. I'll start sending you articles and things. We could go on forever, but we'll have other talks.
We sure will. Thank you.
All right, well, I'm gonna run and do my procedures.
Okay, thanks a lot. Great.
All right, thank you, Ben. Appreciate it.
All right.